Bismillahirrahmanirrahim. Assalamu alaikum. Good afternoon. My name is Nasir Rashid. I'm a neonatologist by profession and currently working in the United States with three different hospital systems. Um, as a brief introduction, I was actually a medical student of Sindh Medical College back in the early 90s. Did my FCPS and post-graduation in Pakistan, completed my FCPS training after my residency at Afan University Hospital, and then moved to the United States in 2002, did my fellowship and residency here in USA, passed both of my boards, and since then I've been practicing as a neonatologist in three different hospital systems. So the topic of presentation for today is birth asphyxia, and it is a pretty common topic when it comes to Pakistan. I think it's a very high rate area when we compare it with the rest of the developed world. Next slide. So before we go to discuss the birth asphyxia, I want to clarify four different terms so that medical students can understand how they are differentiated from each other. The first terminology is called as the birth asphyxia. And if you guys recall uh, from your pathology and medical training, that asphyxia means decreased blood supply. So in 1997, the WHO introduced the term birth asphyxia to describe the clinical condition when the newborn either fails to establish or sustain a regular breathing at birth. So again, as I said, definition by definition is the deficiency of oxygen in a newborn and unable to sustain birth at the breathing at the time of birth. The second term that I want the medical students to be clear about is called as an intrapartum stillbirth, and it is the late fetal death during labor. So these are sort of interchangeable situations where a mom may be going through a very prolonged labor, and the outcome may be a birth asphyxia or an intrapartum stillbirth. A milder form of it, in which probably the newborn survived, but with a lot of complications, is called as a neonatal encephalopathy. And it is described as the disturbance of neurological function in the earliest days of life, and that is manifested by difficulty in initiating and maintaining respiration. In terms of neurological signs, there is depression of tones and reflexes, and it is being divided into three grades called as the mild, moderate, and severe kind of neonatal encephalopathy. The fourth terminology that the medical students should be aware of is called as hypoxic ischemic encephalopathy, which is a syndrome of abnormal neurological behavior, and it is also associated with multi-system dysfunction. So four different terminologies, but they are terminologies and they are interchangeable in a birth situation. So before we move on to the further topic about birth asphyxia and neonatal encephalopathy, I want the medical students to understand what are the intrapartum and antepartum risk factors. And these are important because when you guys will be trained and completed your medical school and goes into your clinical rotation, either in OBGYN or pediatric floor or neonatology floor, these are the risk factors that you have to look into in any baby who is maybe a potential at risk of developing birth asphyxia or encephalopathy. First and foremost is the maternal diabetes, and maternal diabetes is different from the regular diabetes that you guys are aware of, which is insulin dependent diabetes that manifest very early in life when they are when somebody is around like 9 or 10 years of age. Maternal diabetes is a situation where the mom developed diabetes during the time of the pregnancy, and it is also called as gestational diabetes. Here in the United States, as part of the management of the moms, all moms get at least 8 or 9 visits with an OB, and during those visits, their blood sugars are checked and monitored closely and controlled very, in a very fine way. Um, the other most important reason for the birth asphyxia in Pakistan is the hypertensive disorders. And again, I'm not talking about hypertension that is a regular hypertension. I'm talking about a hypertension that happens during pregnancy, and it is being divided into preeclampsia and eclampsia. And we will probably discuss a little bit about those two a little later. The third and the most commonest reason as a risk factor for birth asphyxia is postpartum labor, um, and usually pregnancy is progressed until 40 weeks, and then eventually moms deliver naturally. But in certain situations, the pregnancy can go beyond 40 weeks and may even progress beyond 42 weeks. Um, the obstructed labor and dystocia is a medical condition where either the baby is very big in size and while passing through the birth canal got stuck in the birth canal, or B, the mom has some kind of a pelvic floor anomaly where the pelvic outlet is smaller and the baby cannot pass through the birth canal. The other risk factor is the prolonged second stage of labor. Commonly, we see in moms who are primary gravida and younger mom, they can have a very prolonged second stage of labor. Meconium staining of amniotic fluid, and I'm not sure how many of you may be aware of the term meconium. Meconium is actually the first stool the baby pass, and the babies are not supposed to pass any stool until after birth. But if they are under a lot of stress, whether it is decreased oxygen delivery or decreased blood supply to the placenta, they tend to pass the meconium. And the problem with meconium is that it is so thick and viscous that it gets mixed up with amniotic fluid, and then the baby can swallow that amniotic fluid and eventually can develop pulmonary hypertension or depressed respiration at birth. As we talked about the obstructed labor, the other commonest reason for obstructed labor is a breech presentation. Babies are traditionally supposed to be born with head being first delivery, which we call as the soft leg or vertex delivery, but some around like 5% of the babies are breech in presentation, in which the presenting part is the buttock, not the head. And that is a situation where the baby can get stuck in the birth canal. And I will talk about it also a little later. Vaginal bleeding is also a risk factor for birth asphyxia. Maternal fever, if it is associated with some infection. In Pakistan, I'm not sure how common HIV and syphilis is, but definitely maternal infection like malaria can be a risk factor for birth asphyxia and prolonged rupture of membranes of greater than 24 hours. So again, coming back to the first and the most commonest reason for the birth asphyxia is gestational diabetes. And what gestational diabetes does, as I explained earlier on, gestational diabetes is a medical condition where the mother developed diabetes only during the pregnancy. I'm not going to go into the detail of the pathophysiology of gestational diabetes, but it affects both the mother and the baby. And the way it affects the fetus is that a mom who has a gestational diabetes can have a stillbirth. That means the pregnancy will not progress beyond the second or third trimester, and the baby will die even before reaching the full term. Macrosomia means the baby is too big in size, and as I explained in the previous slide, going back to that it can cause obstructed labor and prolonged second stage of labor. Third is the hypoglycemia. Obviously, that is not a risk factor for any kind of um, uh, the birth asphyxia at the time of delivery, but eventually can cause complications associated with it. Hyperviscosity syndrome, especially polycythemia. These fetuses can also develop hyaline membrane disease, which eventually can lead to respiratory distress and can progress to a decreased blood supply to the brain, hypercalcemia, and some congenital anomalies like septal hypertrophy and left microcolon. On the mother's side, the miscarriage is pretty common. As I said, stillbirth and miscarriage are interchangeable terms. That means the pregnancy doesn't progress beyond the second trimester of life. Polyhydramnios means there's excess amniotic fluid. So there is a natural amount of amniotic fluid in the uterus around in which the baby floats. But if it is more than that natural amount, it is called as polyhydramnios and also can progress to birth asphyxia, birth depression. Infections are common in mother. Preeclampsia, and which is also another reason for birth asphyxia, and preterm labor are the commonest reasons for these babies to develop birth asphyxia. So second cause, if you recall in my second slide, was about the hypertensive disorders, including eclampsia and preeclampsia. So if you look at this flow diagram and going from left side where it says 20 less than 20 GW to the right side where it says diagnosis on the top. So let me try to explain you this flow diagram. Is that under 20 weeks, most women are usually have normal blood pressures. Women who already have high blood pressure at less than 20 weeks, that means they are called as the chronic hypertension patients, and those are different from preeclampsia or eclampsia. But we are not going to go into chronic hypertension. We are going to focus more on the preeclampsia and eclampsia. So as I said, before 20 weeks of gestation, if the blood pressure is normal and then start going into the higher side, then it is called as a gestational hypertension, and then it can progress to eclampsia and preeclampsia. And usually the way it is being diagnosed is that these mothers develop hypertension during their subsequent visit in the second trimester. They start losing protein in their urine. If it is protein, then it is usually preeclampsia. And if it is persistent proteinuria, then it can develop into a medical condition where the blood pressure becomes so high that mom can develop seizures. I don't know how many of you have done the OBGYN rotation, but if you go to the OBGYN rotation, you might have heard about the moms who came for the delivery and all of a sudden developed seizure, or what they call in the Urdu language is mirgi ka daura. So that mirgi ka daura, the one that a women develop during pregnancy, is because of the eclampsia that is related to the chronic hypertension, eventually leading to a stroke or decreased blood supply to the brain. And these are the moms who, when they develop these kind of situations, and their blood supply to their placenta is being compromised, which eventually lead to the baby not getting enough blood supply, and eventually leads to either birth asphyxia or neonatal encephalopathy. So the features of preeclampsia are usually, and as I explained in my previous slide, mothers who are pregnant, they do not have hypertension until the 20th week. And then when they develop hypertension, their systolic blood pressures are 160 millimeter of mercury or higher, and the diastolic pressures are 110 millimeter mercury or higher. And if they are being recorded on two separate equations with at least 4 hours apart, then they are called as the, by definition, the mother, that pregnant lady has preeclampsia. Besides this, they also develop other complications, which include thrombocytopenia, which means that when you do a CBC on these mothers, their white cell and their platelet count is less than 100,000. They also develop impaired liver function, which include elevation of the liver enzymes, commonly A and T. And these are the mothers who also develop right upper quadrant or epigastric pain. If this is not being controlled and treated well, these moms can develop progressive renal insufficiency, which leads to the serum creatinine going up on the higher side and progressing above 1.1 milligram per deciliter. And eventually, these moms can develop pulmonary edema and then new onset of cerebral or visual disturbances. And the reason I have given you this outline of these preeclampsia findings is that when you guys go on the OBGYN floor, make sure moms who are in the delivery phase, their blood pressures are well controlled. And if they have a newer onset blood pressure, and if their answer to the question is yes, that they never had hypertension and developed hypertension during pregnancy, that means they are preeclamptic. those moms need to be very well taken care, because if their blood pressure is not controlled, they will progress to thrombocytopenia, impaired liver function, and eventually can develop cerebral and visual disturbances and decrease blood supply to the placenta. So the baby will be compromised eventually if the blood pressure is not well controlled. Next slide. The postpartum pregnancy, I want the medical students to be very aware of this term in Pakistan, because there's a term called in Pakistan called as "bachcha jo hai wo bada ho raha hai." So that is not the right term. The pregnancy is supposed to be just 40 weeks, and a good healthcare provider should not let the pregnancy go beyond 42 weeks, because once the pregnancy go beyond 42 weeks, there are complications, and those complications can lead to birth asphyxia. So as I said, 40 weeks, the alarm bell should ring off, and either the mom should be induced or should be very closely monitored. But once she crossed 42 weeks and is not in labor, the pregnancy should be taken care by either doing elective C-section or inducing forcefully the small deliver. Postpartum pregnancies have a lot of complication. They sometimes needed help in terms of a induction, uh, and B, sometimes they lead to either vacuum delivery or a cesarean section. Um, as I said, postpartum pregnancy are not natural. So when the pregnancy goes beyond 40 weeks, the perfusion to the placenta is compromised. And as I said, birth asphyxia is a condition where the baby does not get enough oxygen. So there's decreased perfusion to the placenta in the postpartum pregnancy. Um, Also in the postpartum pregnancy, there is less amount of amniotic fluid, and it could cause oligohydramnios. And um, as most of you may be aware of, babies are inside the uterus, floating in a pool of water called as amniotic fluid, and that amniotic fluid provides a cushion to the baby. So if there is less amniotic fluid, the umbilical cord can get trapped in between the baby and the uterine wall, and it can cause cord compression. Uh, Again, postpartum pregnancies are very stressful for the babies, so they tend to pass meconium. So it's a conclusion of many factors. Postpartum pregnancy, decreased blood supply to the placenta, decreased amniotic fluid, baby passing meconium, and the cord compression. All of that can compromise the blood supply to the brain of the baby. Um, the most commonest factors that are associated with postpartum pregnancies, I just want to touch base on those a little bit for for the medical students who may be preparing for USMLEs. And this slide is not for not for your regular day-to-day management, and don't try to use that slide. This is more for like when you are preparing for USMLE, these are the things that you need to know, that what are the factors that are associated with postpartum pregnancy. First and the foremost commonest reason is the unknown dates, and the dates are wrong. Then irregular ovulation or variation in the length of follicular phase. And encephaly, the baby does not have a viable head. So when there is no head, or there's no brain developed, there's decreased production of 16 alpha hydroxy epiandrosterone beta sulfate, and that is an enzyme that induces the labor. Fetal adrenal hypoplasia, which leads to decreased estriol production. Rare conditions like placental sulfatase deficiency and extrauterine pregnancies are also reasons for postpartum pregnancies. So, as I said, this slide is not for your regular day-to-day. When you go to your OBGYN floor, don't start um, thinking about that any mom who is beyond 42 weeks either has an anencephaly, or there's a fetal adrenal hyperplasia or placental sulfatase deficiency. Think of the commonest reason. Commonest reason is either an inaccurate or unknown dates. Okay? The next slide. Um, as I said, when we discussed the risk factors associated with birth asphyxia, obstructed labor is also one of the most commonest reasons. Um, going back to the three causes that we discussed earlier, including gestational diabetes and postpartum pregnancies, what happens is that in a gestational diabetes, because of the excess supply of substrate, the babies come out very big, or they grow in size to more than what they are supposed to be. A typical baby in Pakistan or in any Western world is around 8 to 8.5, even 9 pounds. Anything above 9 pounds is called as a large for gestational age. Any baby who is above 4,500 grams means the baby is large for gestational age. And the baby becomes so big in size that the birth canal through which the baby has to come out, it becomes smaller. So um, I'm sure you guys have heard the term that बच्चा जो है वो बहुत तंदुरुस्त है. So it's good to have a tandurust or a healthy child, but you don't want a sumo wrestler coming out of that birth canal. The other reason for obstructed labor is that the mom may have some kind of a pelvic development anomaly, either the shape of the pelvis is malformed, or B, the uterus has some abnormalities. And those are not commonest reasons, but something to think about. And the only reason that I can think of a normal shaped pelvis in Pakistan is that the vitamin D deficiency is very common. Rickets is common in Pakistan. That can lead to abnormal shaped pelvis. In certain parts of Pakistan, the women tend to be shorter in size or smaller in size. They can have an abnormal shaped pelvis. So those are the factors that have to be looked into. The fetal factors, and this is also important for all of you to understand, because as medical students, when you go into the OBGYN floor, if you are aware of all these risk factors, you will be able to help out more moms and more children to be prevented from birth asphyxia or any complication. So fetal factors that are associated with obstructed labor are persistent occipito-posterior position. So as I said, occipito and posterior position, how should I describe it, is that the baby, when they come out, and if you look at my head in the video, they come out with the head, with the neck a little bit slightly extended. They are not supposed to have the head like this. If their head is like this coming out of the birth canal, the proportion of the head is so big that it will be stuck in the birth canal. But when the baby's head is in this position, the proportion of this side portion of the head is smaller, and the babies can come out. So the position, persist occipito-posterior position, which as I said, is this position where the baby's head is bent forward or flexed forward with the chin touching the chest. Deep transverse arrest, that is something where the baby, instead of the head coming out first, is laying in a side position, as if you are laying on your bed in a side position, and that can also lead to the transverse arrest. Face presentation is also one of the reasons for obstructed labor, and sometimes the shoulder dystocia. So as I said, bigger babies, especially those so-called tandurust babies, are not tandurust babies. If they are bigger than size and more than 4.5 kilogram, their shoulders are not going to go through the birth canal easily, and they can be stuck in the birth canal because those shoulders are going to be big. So you don't want babies with big shoulders, head, like the face presentation, or a breech or a transverse position. These are important things for you guys to understand, as both as medical students and as residents, if you start doing internship in Pakistan or decide to pursue a career somewhere else, that all of these can A, lead either to maternal death, or B, if the mom survive, it can lead to the fistula and to the fetal compromise. There's one other complication of obstructed labor, and I just want to touch base, although it's a little bit off topic, is that when moms survive the obstructed labor, the pressure of the baby head on the posterior part of the uterus is there for such a long time that it creates a fistulous tract between the uterus and the bladder, or between the uterus and the rectum. And these poor moms, oh my God, I watched that video. Dr. Shesha had done a clinic, runs a clinic in somewhere in India. And these moms, when they go through this worst thing in their life of obstructed labor, and then they develop fistula, where they are passing urine through their vagina or passing stool through their vagina. They are being dumped by their family. They've been dumped by their husbands, dumped by their parents, because they think that, God forbid, mom, she is being possessed. Just because literally, this is the term I've heard. I have watched that video, and it brings tears to my eyes to hear about those things, that how those women are being treated in non-educated part of Pakistan. Again, obstructed labor can cause birth asphyxia and fetal death. Um, we are going to and a lot of things that we are talking about seems like repetition, but the reason I want you guys to understand all these things is that these repetitions will make sure that you have correct understanding about this very, very common and very, very important topic. So meconium passage, and why it happens is that these babies, when they get compromised and they get decreased blood supply, either because of the cord compression, and we talked about it, how cord compression can happen. And cord we are talking about is the umbilical cord. So the baby is attached to the placenta through the umbilical cord, and the placenta is attached to the uterus. So mom is breathing for the baby, and then the blood is being oxygenated at the placental level, and from there the blood is being carried to the baby, and the baby gets the oxygenated blood based on how mom is breathing and how the placenta is working and how the umbilical cord is working. So think about it. In any situation, whether it's preeclampsia, the blood supply to the placenta can be compromised, or either it's gestational diabetes, blood supply to the placenta can be compromised, or any other risk factors like maternal fever, malaria, HIV, syphilis, anything that can make the mom sick can decrease the blood supply to the placenta. So with the decreased blood supply to the placenta because of any of the factors in the mom, or things like postpartum pregnancy, now the amniotic fluid is less in volume and the cord can get compressed between the uterus and the baby. What it does is that it can decrease the blood supply to the baby. So the first response to the decreased blood supply to the baby is that Allah Mia has made the human body in such a way, it is such a natural thing, that when there's a compromised blood supply, the first system of the body that gets compromised are the muscles and the gastrointestinal tract. Allah knows how to pray, how to protect the brain, and actually has developed a system in our body that blood supply to the brain is compromised at the last. So when a baby gets blood supply, decreased blood supply um, from the placenta or through the umbilical cord or any of those reasons, what it does is that it decreases the blood supply first to the GI tract. And as we talked about, meconium is the first stool of the baby. So what happens is that when there's decreased blood supply, it leads to increased GI peristalsis. And what it does is leads to anal sphincter dilatation. And the first stool of the baby, which I call as which we know is called as meconium, and it is very thick and viscous, get passed inside the uterus. And then it get mixed up with all the amniotic fluid, and then the baby swallow it, and it goes into its lungs. And that can compromise further the blood supply. So the first hit to the GI tract will lead to the meconium passage, which will lead to the meconium going into the lungs. And when it goes into the lung, decrease blood supply to the rest of the body, and eventually it can compromise the blood supply to the brain. So although Allah has created protective mechanisms whereby our blood supply to the brain is being protected, there is always a limit to any and everything. Um, you guys have to be aware of meconium passage because it is pretty common in Pakistan. About 15% of the pregnancies can develop meconium passage, but only 5% of those 15% pregnancies can develop full-blown meconium aspiration. So don't start this thing that when you go to the OB floor, that every mom who passed the meconium you think can develop birth asphyxia. No, not all meconium deliveries will develop birth asphyxia. It's the meconium passage is the first sign of decreased blood supply. But as I said, if you do the corrective measure, you can change the course. So don't panic if there is a meconium that the baby is going to be compromised. Okay, your OBs are going to be very unhappy with that. Okay. Um, Next slide. This is a very important slide that I just want you guys to be aware of. Um, um, in the Pakistan, the problem is that there's not much documentation available, and people are not being trained appropriately how to deal with these situations. So WHO, in coordination with various institutions in the world, come up with this acronym called as GRADE, and each stands for something. GRADE stands for grading of recommendation, assessment, development, and evaluation during pregnancy. So what they suggest that in order to decrease the incidence of birth asphyxia, and remember, go back to my first slide, if you guys remember my first slide, that if you have a mom who has been followed very closely and has maternal diabetes, it should be taken care of very early in the pregnancy. Has pregnancy-induced hypertension after 20 weeks, should be taken care of very early. If the baby is growing excessively in size, corrective measures should be done earlier on. If by examination mom has some kind of a pelvic anomaly, that should be addressed, and a plan should be made in terms of whether we need to do a C-section. Breech baby, transverse lie, all those things have to be very planned well ahead of time. Um, so if you look at the slide, use of partograph, and I'll show you what is partograph. So I'm just going to read all these things, but then eventually we'll express each and everything in a separate slide. Intermittent assessment of fetal heart rate. And this is something that every resident or every intern, then when they go to the OBGYN floor, they need to learn how to do that. There's a thing called as the fetoscope that they put on the mom's belly, and then they can hear to the fetal heart tone. And I think if you guys can learn that technique and idea, oh my God, it's going to help a lot of babies. I think you can also use the stethoscope, but I don't know that. I have never used a stethoscope to listen to the fetal heart. I think fetoscope is the best thing. Um, I'm not very good about these things because I was in Pakistan 25 years ago. So that time we were told and taught how to use the fetoscope. But here in the United States, nobody uses the fetoscope. We do the electronic fetal heart monitoring, but that is not available as we speak in many hospitals in Pakistan. It might be available in Ahan University Hospital or Liaquat National or bigger institutes, but probably not in every small hospital. So be mindful about that. Simplified umbilical artery Doppler studies. I think that is a technique that where you learn how to use the ultrasound to check the flow of blood in the umbilical artery. I think that is a wonderful technique if you guys can learn it during your medical school or your OBGYN or any of your clinical rotation. Maneuvers to manage shoulder dystocia. It's a little bit more complicated task. I don't think so that a medical student should learn it, but I think people who are planning to become OBGYN should learn it, how to do it. External cephalic version of breech, please do not try it. Please do not. This is not for you. This is for a very experienced OBs to try. Early delivery in preeclampsia and eclampsia. So this is something that I think you guys have to be aware of, is that if a mom who has good antenatal visits and, as I said, develops hypertension after 20th week of gestation, then she is at risk of developing preeclampsia and eclampsia. And as I said, it is very common in Pakistan. This all thing about माँ जो है को माँ को जो है वो हाई ब्लड प्रेशर हो गया और उसको मिर्गी का दौरा पड़ा. It's all eclampsia and preeclampsia. So be mindful about that. and I think learn that how to manage preeclampsia. It's pretty easy. It's not complicated. Using the antihypertensive medication, diet control, all those things that you do for any regular hypertension. Placental abruption, be aware of that term because the placenta is not supposed to be separated from the uterus until after delivery. If the placenta gets separated from the uterus during or early in the delivery, as I said, placenta is the reason. Placenta is the organ that is getting the blood supply from the mom and the oxygen to the baby. So if the placenta is separated from the uterine wall any time before the baby is born, it can compromise the blood supply to the brain and the rest of the body for the baby. Infections, as I said, are pretty common in Pakistan, whether it's GBS or malaria. I'm not sure about the HIV and syphilis situation in Pakistan. I heard that there's some place in Larkana where HIV is now endemic. Not sure about the syphilis in Pakistan, but malaria and infections are very common in mothers, and they should be treated very aggressively during the delivery. And then placenta previa. This is something that is, as I said, if you start using and learn the art of using the fetoscope and the umbilical artery Doppler study, you can also learn how to diagnose the placenta previa with an ultrasound. So learn that art. I think that is a very, very desirable task. It gives you a confidence, even if you do not plan to be an OBGYN, it improves your understanding about this complex topic. As I mentioned, partograph is what now the WHO is recommending for third world countries or places where there is not enough services available for the delivery. I'm not sure how many of you medical students have a plan of going back to practice in some kind of a rural setting like in interior Sindh or Punjab or some small town. But I look at this slide and look at this partograph. And it's a simple document. It's nothing complex. It is just monitoring the progress of the pregnancy and then taking an action if the pregnancy is not going to be progressing the way it is. It is so simple that it can be used by a midwife, a DAI, or anybody. It's a very simple document. So if you look at from top to bottom, it has name, what was how many pregnancies mom had, what day the mom was admitted, what time the mom was admitted, when was the fetal membrane structured. And if you look at it on the second line, there are crossbars and small boxes and squares. And on the left side, it says fetal heart rate, and it starts from 100 in the bottom to 180. And then liquor and molding is the second bar. So look at it, the heart rate is 100. And so the heart rate of a baby should be between 130 to 160 as a normal heart rate. Anything below 130 and start making you concerned about the mom if it is more than prolonged for more than few seconds. But if it is persistently running in 100, that means the baby is getting compromised, and it is much important to do something about it because eventually the blood supply will be compromised that the baby may die or develop birth asphyxia. So again, trying to follow the heart rate with the fetoscope as we talked about, and monitor the heart rate progress, and it should be between 130 to 160. Higher heart rate means the baby is also getting stressed. Lower heart rate means the baby's blood supply is being compromised. And when it comes to the liquor and molding is more that you feel as part of your examination when a mom is progressing through the labor. The nurses who will be working with you on an OBGYN, they will teach you how to feel the fetal presenting part. And that is not the topic that I want to discuss right now. But the liquor part I want to touch base on it is that when the membranes are ruptured, the color of the amniotic fluid should be just like water. And anything other than water is not a good sign. Any smell is not a good sign. So if it is foul smelling, if it is getting green in color and the cream color is getting progressively more greener and greener, that means either the meconium is being passed, and B, if there's in smell, that means there's infection. So both are the things that can compromise the baby. So just looking at the top three boxes, monitoring the heart rate, monitoring the color of the amniotic fluid, and monitoring that progress can give you a warning sign. So if you are in a small rural health setup and you start seeing light change in the color in the meconium and you do not have the expertise to take care of the baby, then it is a sign to start thinking about transferring the mom to a different place. Okay. Um, the two other things that are there, I'm sure, I'm just going to touch base very briefly about those things because I don't think so. Those are important for you as they are important for you as medical student, but I don't think so. You need to learn each and every year. So descent of the head and how the cervix is getting dilated, and this is more for the OBGYN residents. So people who want to be an OBGYN or at least want to do 3 to 6 months of internship in OBGYN, they have to understand that how the descent of the head is happening and how the cervix is getting dilated, but not for folks like me or anybody who's not planning to be an OBGYN. As I said, when coming back to the whole summarizing the things in the way that if the blood supply to the placenta is getting compromised, either because of hypertension, either because the baby is big in size, either because it is post-term delivery, or mom developed a fever, or meconium passage, it can lead to multiple different outcomes. And the first and the foremost is that it can lead to the stillbirth. So baby will just die. Like that's why we have the very highest neonatal mortality rate in the world. Because most of these moms are not being taken care at the right time. So we don't see as much asphyxia as we should be seeing because unfortunately a lot of these babies die. They just die. They cannot go through that whole stressful delivery. And so that is the one. And as I said, in a country like Pakistan, the most commonest reason for stillbirth are obstructed labor, abruption, and preeclampsia. And these are pretty preventable things. Like obstructed labor. Yes, if you are monitoring the mom and the baby is becoming tandarust, you should do something about it. That means mom has diabetes. You have to control that diabetes. If mom all of a sudden develops bleeding, that means the placenta is getting separated, abruption. You have to deliver that baby right away. You do not need to wait. Because once placenta is separated, it's not like that you can put a patch or a tape or something and reattach it to the uterus. That baby has to be delivered. Preeclampsia, as I said, if the mom develops hypertension and you are monitoring that baby mom from the very early in the pregnancy, it has to be treated. And if it is not being controlled, then baby has to be delivered. Malaria, syphilis, and HIV, as I said, I'm not very sure about syphilis and HIV in Pakistan, but I'm very sure that malaria is a very common reason for stillbirth in Pakistan, maternal malaria. This is something that is more for folks who may not be doing internship in Jinnah Hospital, or maybe doing it in Khan University Hospital or Liaquat National Hospital or some better healthcare system. So instead of using the fetoscope, they do something called the fetal heart rate monitoring. And what they do in fetal heart rate monitoring is that a special device that measures the fetal heart rate and transmits it on a monitor is being attached to the mom's belly. And that is a very effective way of monitoring the heart rate. You don't have to go and put that fetoscope or find that stethoscope and listen to the baby's heart every 15 minutes. You just monitor, attach it, and it has alarm set on it. So if the heart rate drops below 100, it will alarm. If it goes above 180, it will alarm. It will remind you. This is a clinical art, and as I said, it is a must for med students doing OB rotation. For folks or students who are planning to do USMLE, they have to learn these fetal heart rate tracing, because I can tell you step 2 and step 2 CS, they will be asking a lot of questions about the fetal heart rate monitoring, probably 3, 4, 5 questions. But as I said, if you have a concept, you can score very well. These are very straightforward questions. The changings in the category tracings are being divided into 3. Category 1 is considered normal. Category 2 is like intermittent decels, means the heart rate will dip down but will come back up. And then the intermittent category 3 means that the heart rate comes down and stays down, doesn't come back up. And that, if category 3 is not addressed right away, it can lead to the hypoxic ischemic injury to the baby, which either can compromise the blood supply to the brain and leading to birth asphyxia, or B, can lead to HIE, means not just compromise blood supply to the brain, but to the rest of the body, and compromising the baby for the rest of his life. Um, I, I'm going to share my email address will be with Mr. Hurram or any of the SMC representative. So if you guys want to understand any of these topics that we talk about, I'm just summarizing everything. But if you want to learn more about category 3 tracing, or want to learn more about placental abruption, or anything, you can shoot me an email and I can discuss it in a more detailed way as part of the separate discussion. This is a slide that I just want to touch base very briefly, that how exactly the, what do you call it, the birth asphyxia happens, the pathophysiology, the thing that you learn in your fourth year pathology classes, where they make this flow diagram and explain to you what is happening at the cellular level, not what you're seeing clinically. But, and these are important to understand, because remember, if any one of you is planning to pursue career in any of the, like UK, United States, you have to understand these pathways, because these are the questions that are being asked during your exams. So as I said, on the top you see hypoxic ischemia. What it does is that, let's tackle the center diagram. What it does is that it causes anaerobic glycolysis. And I'm sure most of you remember your Krebs citric acid cycle, which generates the ATP because of the oxygen delivery. I do not want to go into the detail of that. But if there is no oxygen delivery, then the ATP will be generated at the expense of generating lactic acid. So decrease ATP and rising glutamate. Okay, so that's the one pathway. The second one is that it also leads to increased adenosine. Adenosine eventually gets converted into hyperxanthine, xanthine, and then eventually free radicals. So rising glutamate level and free radical production with increased lactate, all of them affect the cells at the cellular level. And whether it's astrocytes in the brain, or whether it's hepatocytes in the liver, or whether it's nephrons in the kidney, or whether it's myocytes in the muscles, or whether it's ganglion or smooth muscle cells in the intestinal tract. All of those cells generate energy by getting oxygen, and if they do not get enough oxygen through the umbilical cord, which is bring the oxygenated blood from the mother, they develop rising level of free radicals, rising level of glutamate, and increased lactate, and that source can get compromised. And each compromise to each system has different manifestations. We will talk about it later if you guys want to talk about it, but not right now. I think we just want to focus on the topic of birth asphyxia. So how to diagnose the HIE? Coming back to that. First of all, there are three kinds of diagnostic criteria, and this is important for you to understand, because may not be available in Pakistan, and I'm not sure whether even if it is available in Aachen University Hospital or Dawood National or any good hospital. But tier one is the of diagnosis of HIE is a history of an acute perinatal event, which means baby was supposed to be born naturally, but all of a sudden got stuck because of the shoulder dystocia, or contracted pelvis, or placental abruption. And that, if you know that event, that will give you the idea what's going on. And the baby that is born, when you do a blood gas analysis, the bicarbonate will be low, the lactate will be high, and the pH will be low. Okay? And then Apgar scores. Apgar scores are assigned at birth for various different movements in the body, different acts of the baby at the time of birth. And the highest score is 10. The typical Apgar score that is considered a good is between 7 to 10. I have never given an Apgar of 10 to any baby, so no baby get a 10 of Apgar. But traditionally 7 to 9 is what they get at first minute of life, and then at second minute, 5 minutes of life, they get another Apgar score. So if there's a low Apgar score, which means that the baby was compromised in utero, and that's why the Apgar score was low. And a need for resuscitation means positive pressure ventilation, oxygen. That is called the tier one of HIE, or hypoxic ischemic encephalopathy. Tier two is that sonnet stage of HIE, and in that they develop clinical seizures. It is divided into three different categories: stage one, stage two, and stage three. Again, you guys do not need to learn that at your level, just have to be aware of that. And tier three is that you establish and confirm the diagnosis by doing amplitude, amplified amplitude EEG, or a regular EEG. And that will show either the slowing of the brain waves, or B, it will show you some kind of seizure activity. So with that diagnosis being established in Western countries, I am not talking about Pakistan, I'm talking about Western countries. And as I said, I'm not very sure whether this treatment may be available in any of the good setups in Pakistan. The treatment of birth asphyxia is establishing a correct diagnosis, as I mentioned in the previous slide, based on those three criteria of tier one, tier two, and tier three. Once you confirm the diagnosis of birth asphyxia, then you do either two kind of cooling. And I'll just briefly explain you what cooling is. It's called as a total body cooling or selective head cooling. And what cooling does is that it slows down the metabolism. So remember the pathophysiology slide that I showed you guys, that free radicals are generated and glutamate is generated and lactate is generated. That needs to be washed away. Okay? So by cooling the brain, what do? You stop that from being washed away and affect the other cells. You contain it and contain it to the areas where it is being produced. It does not get splashed to the rest of the body. So that is the idea behind doing the total body cooling or selective head cooling. The cooling should be initiated within 6 hours of birth. Okay, so if the 6 hours are passed, the beneficial effects of cooling are gone. So cooling is a very, very sophisticated, very high-end treatment, and it requires a lot of support, not just knowledge of a physician, but also support from respiratory staff, from nursing staff, a good laboratory, all those things. It is a team approach. It's not like Dr. Nasir Rashid will walk in and start cooling a baby. I need a full team to do the cooling. So babies will need invasive lines, which include putting arterial lines in the umbilical artery, venous lines in umbilical veins, or a PICC line to deliver volume boluses, monitor the blood pressure, and giving IV nutrition, correcting the electrolyte imbalances, is starting dopamine for hypertension, giving other blood products if they are needed. And then most of these babies also need respiratory support, and that can be from as non-invasive as called CPAP, just producing pressure around the nose, and that pressure gets transmitted into the lungs and helps in lung expansion, to something called as conventional ventilator, which is breathing by the machine, and then sophisticated machine called as a high frequency ventilation, which breathes around like several thousand breaths per minute in a very small tidal volume. And then last but not the least is a very sort of a you and I breathe that gas in the air in Karachi because there's so much pollution. It's called as a nitric oxide, but you don't need the dose of nitric oxide that you have in the air of Karachi. You need it in a very small dose for babies, and that is called as like 20 parts per million. So when you deliver million cells of uh, um, in a breath, one of them should be of nitric oxide. That's how low dose you need it to improve the pulmonary circulation. So those are very high sophisticated topics. I don't want you guys to get distracted about that. Again, any one of you interested in learning about CPAP, surfactant, like hypertension, dopamine, high frequency ventilation, nitric oxide, total body cooling, asphyxia pathway, you can email me through Mr. Khurram, and I can reply to you in a more detailed way. I just wanted to show you a few things. So I just want to summarize, and then I'm going to show you the various artistry and a little bit of equipment that we use for treating the birth asphyxia. This slide is for the umbilical arterial line, and most of you do not remember the embryology classes, so I'm not going to bore you with that. But if you recall this diagram in your Snell's anatomy in your first year or second professional medical school, the umbilical artery comes at the umbilical stump. These are two arteries, and if you look at it, they're making a U-shaped dip down and then getting connected to the iliac artery. And this is where we put the catheter, either in one right or other the left. And that catheter goes from the umbilical artery through the iliac artery and goes into the aorta. And that catheter gives us access to draw blood, to measure oxygen, to measure the pH, to measure the lactic acid, to measure the liver functions, to measure the cardiac enzymes, you name it. Any lab that I want to draw, I can draw through that line. But it needs very close monitoring. As I said, in the umbilical stump, whenever you go, guys have a time, go to the OBGYN ward and attend the delivery, and don't let them throw away that umbilical cord. Bring out that cord 5 centimeter and then cut it, and you can see in it 3 vessels. 2 are the arteries, 1 is the vein. So the vein is used for giving volume boluses, blood products, IV nutrition, and everything. But go and see that umbilical cord at the OBGYN ward. You'll be fascinated to see what it is. I've never done that when I was in med school, but I think I should have done that. It is a very nice way of understanding the anatomy. This is a picture of a conventional ventilator that we use for babies who are needing breathing support. As I said, it can be a pressure support ventilation, or it can be a volume support ventilation. This ventilator can do both volume and pressure support. We use it here in the US a lot for our babies who develop birth asphyxia. Remember when I was talking about the various respiratory support, high frequency ventilation? This is what we call it, high frequency ventilation. And the fascinating thing about this thing is that when it is running, it mimics the sound of a helicopter. And literally, if you ever come to a NICU in the United States and you go to the bedside, obviously it is not as loud as like a regular helicopter, but the sound of that kind of that, you can hear it from that machine. It's a fascinating machine. It helps in washing off all the carbon dioxide and improve the oxygen delivery to the lungs. Remember, we talked about the nitric oxide that you guys may be breathing right now in the Karachi air. This machine can concentrate and dilute the nitric oxide to the level that is needed for the baby. So we call it the INO delivery system. If you look at it at the display, it says INO in green. So it actually is a delivery system of that gas to the babies, and that helps in lowering the pulmonary blood pressure for these babies. If you can see that slide, that blue blanket on which the baby is lying is called as a cooling blanket, and if you look at towards this picture towards you, you see a machine with various markings on it. That is nothing sophisticated. It's a cooler. But what's sophisticated about this cooler is that this cooler is generating a water at a certain temperature, pumping it into that blue blanket on which the baby is lying, and then returning that water and maintaining that temperature. So that temperature is being controlled very tightly by putting a temperature probe in the baby mouth that goes from the mouth and goes into the esophagus. So how this machine is sophisticated, that machine measures the temperature of the esophageal probe and change the temperature of the water based on that temperature. So you don't want cooling has to be cooling, but you don't want to freeze the baby. So I want you guys to be aware. It is a certain specific temperature that you want to maintain during cooling, between 33.5 and 34 degrees centigrade. Nothing less than 33, nothing more than 34. Okay, so that's a very tight control of the temperature, and that you do through this machine. Um, and that's pretty much it. So in summary, I just want to summarize. In summary, we talked about what are the reason, what are the various definitions of birth asphyxia means. Birth asphyxia itself, neonatal encephalopathy, hypoxic encephalopathy, and stillbirth. And as I said, these are interchangeable terms. Does not mean that they help. They happen in isolation. The second thing, remember, we talked about what are the risk factors in the mom that can lead to birth asphyxia. So as students of OBGYN or medical students, you want to find out which mom is going to be at risk of developing birth asphyxia and catch it early and treat it early, whether it's gestational hypertension, gestational diabetes, contracted pelvis, malaria in the mom, any fever in the mom, malnutrition, any of those things, placental abruption, properly, not properly placed placenta, you figure it out before a baby is about to deliver. Breech delivery, transverse lie, all that stuff. Now comes the third part. Knowing all that, and if you try to address it during the pregnancy, most likely you will have a healthy baby. But despite doing all this, there will still be moms who may not have been picked up very early. So when you are monitoring a baby mom during a delivery for their child, you're constantly monitoring the baby's heart rate. You're constantly checking the heart rate and plotting it down that partograph and looking for any change in fluctuations in the heart rate, change in the color of the meconium, how the cervix is getting dilated, and checking for the presenting part. And if you think that the baby is going to be delivered not normally and needs some kind of help, C-section. If you are in a setup of hospital like Jinnah Hospital or Alphan University Hospital, you snap the finger and the OB will be there. But God forbid, if you're in a rural setup or in a small town, you need to ship that mom to a different facility where a C-section or something can be done. Okay. Once that baby is born, a good resuscitation, it's a separate topic. We can talk about it. If you guys want it, I can do an NRP topic discussion at some point in time. But if that baby is being compromised and developed birth asphyxia, what is the treatment? Treatment is cooling, ventilatory support. Obviously, none of them is available in Pakistan. So the best treatment for Pakistan is early, picking up early those moms who are at risk of developing any kind of compromised birth, and B, treating it at the right time. And if not able to treat it at a level that you can treat it, refer to another facility and try to avoid birth asphyxia to the baby. Thank you very much. Again, my name is Nasir Rashid. I am a neonatologist by profession in Rockville, Maryland. And if you guys need to be in touch with me, and Mr. Khurram can get hold of me. Thank you very much. End of